I'm calling the open session of the Board of Administration to order right now. And first order of business is roll call.
Teresa Taylor,
Here.
Rob Fechner,
Good morning.
Frank Ruffino for Fiona Ma,
Present.
Lisa Middleton,
Present.
David Miller,
Here.
Irena Ortega, Jose Luis Pacheco,
Present.
Ramon Rubalcava,
Excused.
Melissa Willett, here. Dr. Gail Willis,
Gail, can you hear us? We know she's online, so we'll just wait a minute. So go ahead.
okay, and Len Paquin for Betty Yee.
All right. Roll call, and we have a quorum. So now we're going to recess into closed sessions for items 1 and 2 from the closed session agenda. And the board will reconvene in open session following the closed session, but the open session meeting of the board will not continue until after the Pension and Health Benefits Committee meeting concludes. So, thank you, everybody. We have to clear the room. Give us about 5 minutes for closed session, and hopefully making sure Gail's there.
Yeah.
That'd be nice.
If I'm here, can you hear me?
Yes, Gail, you are here.
Ramon Rubalcava.
Unmute yourself, Ramon.
Sorry, I'm here. I can't seem to get the screen.
Lisa Middleton.
Present.
David Miller.
Here.
Irene Ortega. Jose Luis Pacheco.
Present.
Teresa Taylor.
Here.
Melissa Willett.
Here.
Lynn Paquin for Betty Yee.
Here.
Thank you. Agenda item 2, executive report. Mr. Sweeney.
Good morning, Mr. Chair,
Morning.
members of the committee. Anthony Sweeney, CalPERS team member, and I'm happy to be here today to share a little update from our customer service and support team. As you know, last month we held a successful return to our first in-person CalPERS benefit education event in Oakland. It's the first in-person event since February of 2020. And I want to thank everyone involved for the phenomenal job that they did putting this together. We had nearly 700 members attend over the 2 days, and it was great to see them interacting with the team in person. It seemed like they were happy to be back. It was evidenced by our 99% satisfaction rating for the overall event and for the classes, which is the highest we've ever had, actually. We're now planning our remaining CBs for this fiscal year, 2 virtual events, one in December and one in February, and then we're planning our next in-person event for March in Anaheim. I wanted to share a quick member story from the Oakland CB. We had an inactive member who separated from his CalPERS employer over 10 years ago. Walked into the event, he knew he hadn't maximized his benefit factor and intended to retire at age 63, which was a year away. But anyway, our counselor escorted him to one of the kiosks and informed him we could run an estimate for him. Knowing that he had been inactive, we decided to run an estimate as of that day that he attended. The member was happy to see the amount that it was, but he still was interested in potentially waiting for another year. So we ran the estimate for a year out, and the difference was a mere $3. So we helped him submit the retirement application right there online at the event, and he left the event retired and extremely happy, as you can imagine. So great event, great results.
Excellent.
So speaking of retirements, I wanted to give an update on how retirements from the 21-22 fiscal year compared to the 2021 fiscal year. So overall, our retirements were down 7.6% compared to the prior year. The state was down about 17%, public agencies down about 6%, and schools were fairly steady, down just 0.5%. Looking at just safety retirements, they were down about 17% overall and 25% decrease in state safety retirements. Interestingly enough, the decrease of about 8% from this fiscal year or last fiscal year to the previous year was almost identical to the increase we had from the year before that. So when you look over the last 3 fiscal years, it's pretty stable overall. I also wanted to acknowledge that this week begins our health open enrollment period for our employers, active members, and retirees. And this is traditionally the busiest time of year for our contact center. But last year, we were able to reduce caller wait times by 78% and increase the number of calls we answered by 34%. So this year, we're doing everything we can to sustain that and continue a smooth experience. And I want to thank our agents and support teams for their extra hard work during this busiest time of the year. Since we last met, there have been several environmental events that have impacted our retirees. As I've mentioned before, our teams continuously monitor disasters year-round, reaching out to members who receive paper checks and may be impacted by mail deliveries. So far this season, there have been 50 fires and even a flood back in Kentucky that we have been monitoring. We've made calls to nearly 100 impacted members who have paper checks and impacted postal service delivery. Most are okay with the mail being redirected or waiting for their checks to be delivered, but we were able to switch 7 of those members to direct deposit, which is our ultimate goal. Just a little bit about the limited duration regs. As you're aware, we're working to define the term limited duration as it applies to retired annuitants and temporary upgrade pay appointments. And the public comment period ended August 1st for those regulations. We're working on reviewing those comments, preparing responses, and making modifications to the proposed language. And we'll bring those revised regulations back to the committee in November. If you receive any questions from your constituents in the meantime, I'm happy to be a resource, so please reach out. Lastly, yesterday you heard a presentation from the CEM benchmarking group, and it was stated that CalPERS is the most complex system in the 500-plus plans that participate in CEM. I just wanted to let you know that this complexity makes it that much more difficult for our team to always deliver timely benefits and superior customer service, but they always seem to come through. So I just wanted to thank our teams for their continued hard work and dedication. And that concludes my update, and I'm happy to take any questions.
Very good. Thank you for your report, and thank your team for constantly doing a good work on our members' behalf. I do have a question for you, Anthony. On some of these Zooms that I do, I often get questions about people saying, how do I get my retirement money if I retire and leave the country? Is there a way that we could post, because I know we can send checks, but there is a limit of where we can do direct deposits, correct? Is there a way that that could be put on the website somewhere, that list of countries where we can't send direct deposit?
Yeah, there's certain banks that have connections with the foreign countries that are able to do the direct deposit approved transfers, and there's others that don't allow that. So let me take that back, and I can look into if there's any more information we can provide.
That'd be great, and even if we could give a list of the banks that they can use in another country, that might help stay off some questions in the future.
Sure thing.
Great, thank you. Seeing no other requests, thank you. Mr. Molds.
Morning, Mr. Chair, members of the committee. Don Molds, Chief Health Director. Before we get to the agenda, I want to provide a few updates. As Anthony mentioned, open enrollment started this past Monday, September 19th. It runs through October 14th. This is the annual time of year our members can enroll in and make changes to their health plans and add or remove dependents. All of the information a member needs to research plan choices and the 2023 premiums and benefits are available online in my CalPERS and our website on the open enrollment pages. Next, at past committee meetings, you've heard public comment from our retiree stakeholders about the Medicare ACO REACH model. I want to let you know we'll be holding an education session on ACO REACH in January at Board Education Day. We'll have a panel of speakers offering various views and dive into the program so we can better understand it. My goal is to have clear direction from the board that we can use to engage CMS and others in DC. This is an important topic. I look forward to delivering an informative session for everyone in January. Next, I want to update the committee on the long-term care managed care solicitation that we've discussed in the past and also earlier this year. By way of reminder, the managed care solicitation is our attempt to bring new benefit designs that we believe can reduce costs for CalPERS and our long-term care policyholders by helping them stay in their homes longer. As we've discussed in the past, we also see helping our policyholders stay in their homes longer as a significant potential program improvement, since staying in their homes as long as possible is what all our policyholders consistently tell us is what they want out of the program. I'm pleased to report we have an intent to award in place with a bidding vendor for that would-be program pending successful contract negotiations. If we're successful, we'll communicate to you and to policyholders the details of the program likely in early 2023. I should caution that we still have a lot of work to do before we reach terms. Specifically, we won't be able to move forward with the contract unless there are strong performance guarantees in place that minimize any potential risks to the long-term care program. Next, I want to quickly highlight some of the great work by the team. One area of focus this past year has been telehealth, where we wanted to better understand the quality of our services our members receive and how we can improve them. Our health innovation team led work in this area in collaboration with RAND to better understand how telehealth services measure up. I'm pleased to report that our study and its findings will be published in the journal Health Affairs in December. In November, we'll have the opportunity to share the CalPERS journey on health equity. We're one of only a few purchasers leading the way in collecting demographic information that includes key data on race, ethnicity, language preference, sexual orientation, and gender identity. We'll be presenting our health equity initiative at the National Committee for Quality Assurance annual meeting in Washington, D.C. this November. And speaking of health equity, starting this Saturday, September 24th, health subscribers will receive a $10 gift card from their plan by completing their health demographic profile either in My CalPERS or through the link available on our website. We're excited to partner with our plans and offer this incentive because gathering this information is vital to our health equity work. As we've said in the past, understanding the demographic information of our members has the power to reveal important trends and help us and our health plans identify whether changes need to be made in the way care and treatment is provided to ensure it's equitable for all of our members. We'll be communicating this gift card incentive to our subscribers throughout open enrollment and over the next couple of months, and we'll come back to you with how we did. That concludes my remarks. Happy to answer any questions.
Seeing no requests, thank you very much. Moving on to item 3, action consent items. We have 3A, the June 14th committee meeting minutes. 3B is today's timed agenda. What's the pleasure of the committee? Moved by Taylor, seconded by Pacheco. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Item 4, information consent items. Having no request to pull anything off, we move to agenda item 5, action agenda items, proposed revisions to PEMCA. Mr. Molds?
Yeah, and I will turn things over to Yesenia Croft from the Health Account Management Division.
Very good. Good morning. Not yet. There you go.
Thank you. Good morning, Mr. Chair, members of the committee, Yesenia Croft, CalPERS team member. Today, I bring forward an action item to approve revised proposed amendments to the Public Employees Medical and Hospital Care Act, Regulation Section 599.500, Subdivision O, definition of parent-child relationship, so that it may be released for an additional 15-day public comment period. On March 16, 2022, the board approved the formal process to amend the regulation to clarify a dependent's eligibility in a parent-child relationship. On June 3, 2022, we submitted the public notice package to the Office of Administrative Law, commencing the 45-day public comment period, which formally closed on July 18, 2022. CalPERS received 2 public comments during the 45-day public comment period. Public comments pertain primarily to children who are not yet school age and those who are new to the program. Concerns were expressed as to whether the documentation requirements for these individuals were too burdensome. One commenter felt that the added specificity in the proposed regulation was overly narrowing. However, the intent of the proposed regulation changes is to add clarifying language as to the types of primary and secondary supporting documentations required to certify the financial dependency of more than 50% of an employee or an annuitant's support. In addition, the current regulation provides multiple alternative ways to demonstrate a dependent's eligibility as a parent-child relationship. For example, for dependents under the age of 19 a copy of the first page of the employee or annuitant's income tax return from the previous tax year listing the child as a tax dependent is required. However, to address the newly acquired dependents in a parent-child relationship for a time not to exceed one tax filing year, the employer annuitant may submit other documents that substantiate the child's financial dependence. For children who are not yet school age, school records may also include preschool and daycare records showing the employer annuitant as having legal parental status or guardianship over the child. In addition, other verifiable documentation is acceptable, such as medical bills or proof of medical and dental insurance. Secondary supporting documentation may also include daycare or preschool payments, proof of payment by the employee or annuitant for activities such as sports registrations, fees, music lessons, or swimming lessons, etc. In the instance where an employee or annuitant is unable to comply with the parent-child relationship requirements and certify financial responsibility for the dependent child within the required time frame, they may request enrollment during a subsequent qualifying event such as open enrollment or as a late enrollment request, providing them additional time to secure the required documentation. Public comments also indicated concern with the requirement that supporting documentation not be older than 60 calendar days from the date of signature of the affidavit of parent-child relationship, as some of the documents are likely to be outside of the 60 days due to the nature of the document type. To remedy this issue, we updated the proposed language to include an exception to the 60 calendar day requirement for legal judgments, court documents, child driver's license or state identification, or vehicle registrations. All other supporting documentation will maintain the 60 calendar day requirement. Another public comment included a recommendation to add regulatory language to provide an employee or annuitant 1 year from date of death of their spouse or domestic partner to certify the child or children of the deceased spouse or domestic partner as a parent-child relationship. However, this recommendation is not necessary, as existing law provides that stepchildren and domestic partner children remain eligible for CalPERS health benefits as a dependent and may remain enrolled on the employee or annuitant's account until they turn 26, or until the employer annuitant remarries or registers a new domestic partnership. CalPERS will clarify this in future guidance to employers. With committee approval of these changes, we will move to submit our public notice package to the Office of Administrative Law for an additional 15-day comment period. We also seek approval to submit the final rulemaking package to the Office of Administrative Law upon conclusion of the comment period if no additional comments are received. This concludes my presentation, and I'm happy to take questions.
Very well. Let's see, I have no questions at this time. This is an action item. What's the pleasure of the committee? Moved by Pacheco, seconded by Miller. Any discussion on the motion? Seeing none, all in favor say aye. Aye. Opposed, no. Motion carries. Thank you.
Thank you.
Brings us to agenda item 6A, PPO strategic alignment. Mr. Molds.
Morning, Mr. Chair, members of the committee. Don Molds, CalPERS team member. I'm here with Rob Jarzambek and Julia Logan to present an update to our PPO strategic alignment effort, and I'll pass it to them shortly, but I want to start with some background. So at the June 2022 Pension and Health Benefits Committee meeting, we shared some challenges facing the basic PPO program. As a reminder, the basic PPO plans have experienced premium increases in volatility over the last few years. In 2021, they saw higher than expected medical and pharmacy costs, as well as investment-related losses. Both of these contributed to a large reserve deficit. To address the deficit, you approved a 5-year surcharge to the basic PPO premiums to replenish reserves starting with the 2023 plan year. In June, we also informed you of concerns the health team had about possible near-term and longer-term affordability challenges facing the PPO. At the time, we were particularly concerned about the PPO Gold product. In July, we shared with you that the team had begun additional financial analysis of both PPO products and that we are exploring options to help address some of the challenges facing the PPO. We're here today to present our initial findings and to start to lay out some of the options we may bring you in November for consideration. There are several key goals of the work that's currently underway. These include ensuring that pricing for the CalPERS Basic Gold product stays in line with the pricing of our low-cost HMO products, and identifying potential interventions that could help curb near and longer-term costs for both products. There are also non-cost related goals as well. One is ensuring that both PPO basic plans are aligned with our strategic goals and that the PPO quality measures and health plan requirements are consistent with those in the HMO solicitation, which is currently underway. A second is integrating lessons learned into other CalPERS plan offerings. And the last is developing the foundation for our upcoming PPO contract solicitation for calendar year 2025 through 2029. I know that seems like a lifetime from now, but it really isn't. As you'll see, this effort has highlighted the need to assess how the PPOs are structured, as well as the financial arrangements we have with our third-party administrator, Anthem. As you know, we have a range of financial, contractual, and policy considerations that impact premiums that do not inherently relate to the underlying care delivery. They include the nature of the funding for the PPO program, so self-funded versus insured, and how risk between populations is managed. We also seek financial arrangements with our contracted health plans and our third-party administrator that ensure members get the highest quality care. Mechanisms include CalPERS supporting administrative functions related to administering the PPO administering the PPO at risk for outcomes, and having strong quality incentives. As CalPERS plans its solicitation for the 2025 PPO contract, we'll review options to encourage both lower cost and higher quality care. I'm going to pass the baton to Rob in just a second, but before I do, I want to update you on a concern I raised earlier in the summer. When you approved 2023 rates in July, the health team was worried that cost growth in the PPO basic plans was significantly outpacing cost growth in our HMO products, and that the rate of growth, coupled with member responses to those changes, could create profound challenges to the PPO, particularly the Gold product, as early as in 2024. Our analysis has identified several areas where PPO costs need to be improved, but it also shows that generally the underlying medical and pharmacy cost growth in the PPO is in line with that of our HMO products. This is largely good news because it tells us that the PPO is not facing an imminent sustainability crisis. The message of the presentation today is that we have a lot of work to do to improve the cost of our Platinum and Gold PPO products. We aren't facing an immediate sustainability crisis, though. Rob and Julia are going to go into all of the details, but I thought I would start by sharing that largely positive news for the context on the work we're doing. I'll turn it over to Rob now to share more details about the work that took place over the summer and that's being conducted now. He and Julia are also going to share several initial findings. So, Rob.
All right, thank you, Don. And good morning, Mr. Chair and members of the committee. Rob Derzambek, CalPERS team member. To research all the items Don just described, we assembled a team and engaged our third-party actuarial firm, Milliman, to help us better understand our data. We were also fortunate to engage Peter Lee, former director of Covered California, to help inform and guide our research. With both Milliman's and Peter's knowledge and expertise, we are analyzing current and historical healthcare cost and utilization trends in our PPO and HMO basic plans. We continue to work closely with Anthem to lower costs while ensuring members have access to high-quality care. We are also researching other models so we can begin conducting an informed and thoughtful PPO procurement in 2023. In the same spirit, we are looking at other structural changes to the PPO program as well. So let's first start with industry engagement. With Anthem, we are looking at the PPO costs relative to the costs in the HMOs and learning more about what additional tools they may have to improve costs and outcomes for our members. We are discussing network design, quality, and management options. This will be a major focus as it has the potential to save money and improve outcomes for members. As we engage with Anthem, we are focused on interventions we can implement in the short term, as well as the next plan year, which starts in 2024. But we are also looking at longer-term interventions that will likely make more sense as part of our next TPA contract, which will be in place starting in January of 2025. Next, we are collecting independent data and held detailed inquiries with entities serving large purchasers. These are entities that provide member navigation and advocacy programs, which you might know as navigator systems or assistance. Others provide virtual care options, and some have programs that target individuals with particular conditions. Lastly, and as part of our normal course of business, we're engaging with other large purchasers and purchaser groups. With them, we're exploring new models that may allow us to better serve our members. As we approach the end of our 5-year PPO contract and prepare for the next solicitation, this research and engagement is helping us better understand some of the innovative and value-add services we might consider for our members in CalPERS PPO plans. Before I turn things over to Dr. Logan, who will be talking about what we are seeing in some of our data, I want to spend a little time unpacking the various cost drivers in the PPO. So let's start with the 2023 basic PPO premiums. The blue bar on the right shows we had an overall increase of 15.76%. When we break things down, we see that healthcare cost increases account for 8.5%. 4.9% of this was medical, 2.6% pharmacy, and 1% was other. So this category includes several components, but combined together had a net impact of a 1% increase. There was an under projection for 2022, which accounted for 2% of that premium increase. This under projection is combined in the medical increase in the chart. So 2% of the medical's green bar of 6.8% was this under projection. And lastly, structural adjustments made up 5.3%. 2.6% came from a snapback from buying down the 2022 premiums, and 2.7% is to rebuild reserves. So the under projection and structural adjustments are responsible for almost half of this year's PPO rate increase. As you know, this rate increase is significantly higher than the average HMO increase of 4.35%. However, it's important to take a multi-year view when looking at premiums and not just focus on a single year. This chart shows the average basic PPO and HMO premium increases since 2018. Comparing the 2018 and 2023 premiums, the overall average annual increases are similar for basic HMO and PPO. The 6-year average premium increase for HMOs is 3.2%, and it is 4.2% for PPOs. You can see that the PPO rate changes have shown more volatility, with a rate decrease in 2018 and then a high increase in 2023. But much of the premium volatility in the PPO is driven by structural issues rather than underlying healthcare costs. For example, we had the premium buy-down, which artificially lowers premiums for the year and causes a snapback if the same amount of money is not applied to those premiums again in the subsequent year. And we also had a premium surcharge for the 2023 basic plans to start rebuilding reserves. Finally, this chart shows the weighted average basic PPO and HMO premiums for the same time frame. So going to slide 8. You can see that they are relatively similar despite the volatility in the increases and decreases we just saw on the previous slide. The premiums for the HMO and PPO are similar in 2018 and 2019, but diverged in 2023. This highlights Don's comments that while we need to continuously look at how to improve the value in the PPO program, in the short term, the PPO does not appear to be in jeopardy of being unsustainable. Let's talk more about the exploratory analysis that we've done so far. CalPERS has engaged Milliman to perform an in-depth data analysis to identify potential areas for improvement within the basic PPO program. The analysis involved direct comparisons of the basic PPO to non-Kaiser HMOs based on medical and pharmacy data from 2017 to 2021. We also did indirect comparisons to Kaiser. Some of the early findings include that PPO cost growth is not increasing at a faster pace than HMO cost growth. The same cost trend exists for medical and pharmacy, and we'll see this on the next chart. Utilization is similar between PPO and HMO products. Said differently, in general, PPO members are not going to the doctors more often than their HMO counterparts. We've identified the top contributors to the increased cost in the PPOs, and these are unit costs related to hospital outpatient services, chemotherapy, specialist care, outpatient labs, and imaging. Julia will talk about these in a moment. Finally, as with healthcare spending in general, a small percentage of individuals account for a large proportion of the expenditures. Julia will also explain what these conditions are and the members who comprise this group. As part of our analysis, we have looked at all members in the PPO, and because the PPO has a higher proportion of early retirees and individuals in rural areas, we looked at the distribution of members' cost among active members and members in urban areas. The cost differences are consistent amongst these two groups. So the main take-home is that the difference in cost between the PPO and HMO plans is not driven by one thing, but there are several key drivers. So this slide shows the historical pharmacy and medical cost trend between PPO and HMO from 2017 to 2021. Other than in 2020, which was a unique year because it was the height of the COVID pandemic, the historical trend for PPO costs is in line with the HMOs at around 3 to 4% on an annual basis. While cost growth in the PPOs is not higher than in the HMOs, costs continue to be higher. And it appears that a major driver of this difference is that unit costs in the PPOs are higher than those in the HMOs, rather than members in the PPOs using more services. So as encouraging as it is to know that the PPO is not increasing at a faster pace than the HMOs, the fact that unit costs are significantly higher is a problem. Our main objective moving forward is to better understand why this is so we can reverse that difference. The last thing I'd like to draw your attention to is the 2021 column on this chart. The PPO costs were $766 and the HMO costs were $664, which is reflected here as a $103 difference due to rounding. I'm going to turn it over to Julia to help us understand this $103 difference or so.
Thanks, Rob. Good morning, Julia Logan, CalPERS team member. To help understand the drivers of the cost differences, we looked at all major service areas and assessed the extent to which the higher costs in the PPO program are driven by using more services or higher unit costs. This slide that you see shows the top 8 service areas out of over 140 to give you a flavor of that variation in cost per member per month. The table is sorted based on how much the service category contributes to higher costs in the PPOs than in the HMOs. Let's look at that top row as an example, which is specialty drugs. In 2021, the per member per month cost for specialty drugs was $16.78 higher in the PPO plans than in the HMOs. Now let's dig into that $16.78 a little bit more using the 2 columns on the right. There are 2 components of healthcare costs, the utilization and the unit cost. Higher unit costs in the PPOs than the HMOs account for $11.03 of the $16.78 cost difference for specialty drugs. The other $575 comes from higher utilization in the PPOs. The second row of the table, it says surgery hospital outpatient, tells a different story. The PPO utilization is actually lower for that service category, but the unit costs are so much higher than the overall PPO costs, making the overall difference $9.37 higher in the PPOs than the HMOs. So as you can see, moving to the bottom row in black, the total of the $102 difference PM between the PPO and the HMO, the difference is overwhelmingly driven by higher unit costs. And as you heard earlier, this difference in healthcare costs has been pretty consistent over the past 5 years. And also, as Rob mentioned just now, utilization doesn't appear to be the big driver of that cost difference. Rather, there is a somewhat lower utilization, meaning that if the PPO cost per service were the same as the HMO, the program would actually cost about $29 per member per month less. The driver is higher unit costs. Those higher costs are particularly striking in some areas and deserve more attention, such as outpatient surgery and radiology and labs, which will come up later when we discuss some of the intervention options we're exploring. But the key story is that the details matter, and we have been rolling up our sleeves to look at issues such as how the variation in costs are impacted by where members live. Are there different utilization and cost patterns in Northern versus Southern California? And how much, if at all, are higher unit costs driven by out-of-network utilization? And could higher costs be driven by higher severity of illness of members receiving care? Studies on healthcare spending generally find that a small percentage of individuals account for a large proportion of expenditures, and CalPERS, as it turns out, is no exception. What we see here is that the most expensive 1% of our PPO members, those at the top of the pyramid in that lighter orange, accounted for almost 40% of the costs in 2021. In contrast, the least expensive 44% of members at the bottom of the pyramid in darker blue accounted for less than 2% of the costs. Almost half of our PPO members incur annual healthcare costs of less than $1,000, while 1% of our PPO members incur more than $100,000 in healthcare costs every year. And the 6% with costs over $25,000 account for over 2/3 of our spending. And this is really more than an exercise in divvying up our data in interesting ways. It really helps us delve further into who those at the top higher cost members are, what's driving these costs, and really start to explore the answers to questions like how can care be managed better for those high cost, high needs members. On the next two slides, you'll see that
Dr. Logan, before you go on, do you want to take questions as we go or wait till you're done?
should we?
It's your prerogative. I think it might be easier to do them afterwards, but if you have questions and you think it's
I don't, but I have a couple of board members that do, so we can wait? All right, we'll wait then. Continue on.
Okay, thank you. We'll go on. On the next two slides, you'll see that we've taken a deeper look at members with complex health conditions. This slide focuses on some of the members at that top of the pyramid, the members who are highest cost with highest medical needs. On this slide, we're looking specifically at those members with a cancer diagnosis, because this is where we saw some really high costs and some large differences between the PPOs and the HMOs. You'll notice that the prevalence, or number of cancer cases as a percentage of all members, is consistent between the HMOs and PPOs. For example, about 0.8% of PPO members and 0.7% of HMO members have had breast cancer in 2021, a little less than 1 in 100. And the percentage of members with lung cancer is 0.1%, or about 1 in 1,000, in both the PPOs and the HMOs. We do, however, see large differences in the cost of care for each diagnosis. The average cost of lung cancer care in the PPOs is over $84,000, and in the HMOs, it's about $50,000. Among CalPERS PPO basic members, only 1.5% of them have one of these 5 cancers noted, but they have spending over of $189 million. And as you can see, while the rates of cancer are very similar, the costs of care for these individuals often appears to be far higher in the PPO than the HMO. We're digging into this to see how we can be sure our members with cancer get the best care possible. This next slide continues to look at our higher cost, high needs members, and this time takes a deeper look at chronic conditions. In the case of chronic conditions, we see that in general, both the prevalence of the condition and the average cost to treat each person with a diagnosis is very similar between the HMOs and PPOs. The notable exception here is depression, where the prevalence of depression is somewhat higher in PPO members, as is their average treatment costs. This data puts the spotlight on how important it is for both HMO and PPO members to focus on quality and getting appropriate care for our members with chronic conditions. Many members with chronic conditions have annual costs ranging from $4,700 for diabetes to almost $14,000 for substance use disorder, and there are thousands of members with these conditions. We're trying to ensure that our PPO members with chronic conditions are being well served and investigating how we can intervene on improving value and the coordination of care for these PPO members. Excuse me. And this is where our interventions come in. Based on the data analysis that we just reviewed and the industry engagement that Rob discussed a few minutes ago, we're developing and refining a menu of potential interventions to address the underlying quality, experience, and affordability of the care provided through our PPO program. In addition, we realize that some of our members need more of a hands-on approach to their care than others, especially those with higher needs. You will see that theme throughout each of the categories on this slide. Research in this area indicates that members who receive effective care management have a better experience and better outcomes. And in my experience as a clinician too has told me this time and time again. First, I'll start with network design, composition, and structure. High-quality provider networks that are accessible to our members are an absolutely crucial part of being able to achieve our strategic objectives. The team is doubling down on our work to investigate the network design differences between PERS Gold and PERS Platinum and how those networks relate to the offerings available through our CalPERS HMO and EPO products to inform potential network changes to improve quality, cost, equity, and access. Next, behavioral health. As we've discussed together as recently as the July offsite, access to high-quality behavioral health is essential to effective high-quality health care, but the challenges, as you know, are many. Additionally, our data analysis shows that most behavioral health services, inpatient, outpatient mental health, and substance use services, both utilization and costs are higher in our PPO plans. Part of what we will be doing between now and when we next meet together in November is to better understand why this is. It may be in part to higher use of out-of-network clinicians, so we will be investigating options to expand in-network availability of behavioral health clinicians while simultaneously improving coordination for our members with behavioral health needs. Pharmaceutical strategies. Clearly, controlling pharmacy cost is essential for the ongoing success of our program. We've been engaging with Optum on various strategies, including supporting members to use Optum Rx home delivery to fill maintenance medications, and using industry best practices for enhanced utilization management for some specific specialty drugs to ensure that members receive clinically effective medications in a timely manner. Reference-based pricing. This is a benefit design strategy that aims to address unwarranted price variation and creates an incentive for members to select lower price care options for the same services. Because our analysis shows outpatient labs as a top driver of per member per month costs, with higher utilization and higher unit costs in the PPOs compared to the HMOs, we will be exploring expanding our existing reference-based pricing programs to include outpatient lab services. Next, I'll touch on both member navigation and condition-specific support together, because they really do go hand in hand. We can see from our utilization and cost data that clearly chronic health conditions require a comprehensive approach to care. Currently, PPO members with complex high-needs conditions such as cancer and chronic health conditions receive support for treatment through various care management programs. We're looking to maximize existing efforts where possible. And, if you can go back to the previous slide, thank you. Where possible, and are engaging with Anthem and potentially others to explore additional programs to better identify members at high risk and emerging risk who could benefit from support and timely access to the best possible specialty care. In tandem with this effort, the team is investigating options to expand in-network availability of clinicians and options related to networks, benefit design, and alternative delivery models to continue to improve health services, including behavioral health and oncology care. Site of care management. This is a really important aspect of controlling costs in the PPOs, because costs and quality for the same treatment can vary widely depending on where the care is administered. As part of this work, we have identified opportunities to improve the care experience for high-complexity members while lowering overall costs through a Centers of Excellence program for targeted high-complexity conditions. Such a program would apply lessons from CalPERS, other purchasers, and health plans to potentially build a program to include certain procedures or conditions. And certainly, but not least, primary care. As we've discussed in the past, high-quality, equitable primary care is the cornerstone of our healthcare system and our program. CalPERS wants to support members by ensuring access to effective primary care and by ensuring that members with complex health issues are supported by a coordinated team of providers working together to meet each individual's needs. We're investigating innovative primary care models that build on our statewide partnerships, such as the current Advanced Primary Care Measurement Pilot, and are exploring how primary care, integrated behavioral health, and team-based care may be better delivered to our members. PCP matching for our basic members in our PPOs starting in 2023 is an important step in establishing a strong primary care foundation for our PPO members. Now you can move to that slide. Thank you. And before we move to questions, we wanted to share a project timeline to give you a sense of where we're going. And as we mentioned, we'll be sharing our proposed interventions for 2024 to you in November based on your feedback today and our further research and analysis. And further, we will be incorporating our learnings into the 2025 PPO solicitation. That concludes our presentation. Dawn, Rob, and I are happy to answer any questions and look forward to the discussion. Thank you.
Thank you. Thank you all for the presentation. We do have a few questions. I'm going to start with one on slide 13, your cancer slide. Since there seems to be such a large disparity between the PPO and the HMO, do we have any list of outcomes? Are the outcomes percentually higher, better outcomes for the PPO versus the HMO, or are they relatively static?
Yeah, that's a really excellent question, and one that we've been wondering as well. Often our claims data doesn't necessarily tell us the whole story, so we have been partnering with Anthem to get at more of the clinical outcomes and what that really means in terms of our members and their care.
Great, and I know that certainly HIPAA falls into that line as well, but it would be nice to be able to have some kind of comparative figures and looking at whether or not it's a big difference for the PPO side versus the HMO side. I mean, if it was a big difference, you might have more people trend to the PPO side, for instance. So, all right.
Outcomes are and Julia knows this far better than I do, but outcomes are both the hardest thing to get at and the most important thing to get at. And that's one of the foci of this whole exercise has been figuring out where we can get a better accounting of outcomes.
Great, thank you. Before I go on to questions, I do want to say that Mr. Rubalcava is joining us remotely. He's attending other meetings. He stepped out before our action item number 5. That's why we did not do a roll call vote. He was no longer on the line. He came back on after action 5, and he now has a question. Mr. Rubalcava.
Number 11. I noticed in comparing the outpatient surgery and the inpatient surgery, it seems like counterintuitive that the inpatient inpatient surgery will have a lower cost. But I know this is just a difference, and it doesn't actually show the actual dollar amount. So is there something that's easily explainable, or is there something here that needs to be explored further between the cost on hospital outpatient surgery and inpatient surgery? Because generally, inpatient surgery, we've been told, is more expensive.
Mr. Rubalcava, it was a little hard to hear you, but I think your question was related to the hospital outpatient surgery versus inpatient surgery.
Correct. I missed that, Emily. Yes.
So, yes, the utilization for both outpatient surgery and inpatient surgery is lower than the HMOs, but the costs are higher. So we're looking into that more about what those differences really are. Go ahead, Don.
I was just going to add that inpatient, so this doesn't capture total costs in either of those categories.
Okay. That's what I asked. Yeah.
Right.
Okay. So it's just, okay, good. I was wondering. All right. And then the other question is, I think you already answered it. There was a lot of discussion in the memo and also towards the end. One, I want to commend the staff on this whole data analysis approach. And I was intrigued that there's going to be some intervention proposals regarding benefit design and, more importantly, network design. And so I'm looking forward to that in November. So I look forward to the reports. Thank you very much.
Thank you, Mr. Rubalcava. I have Ms. Taylor.
Thank you, Chair Fechner. I think I mentioned this before, but as we're looking at these costs that are higher than the HMO costs, and I remember being at a offsite where we had brought costs down for urgent care and emergency room services, and then costs went up elsewhere. So I'm afraid once you get this resolved, right, that it's going to go up elsewhere. How do we mitigate these factors of grabbing profit where they can?
Yeah, so that can be a problem when you're dealing with a single entity. So if you're an insurer negotiating with a large medical group, for example, we see this all the time in national data and in some data about California, is that you focus on an area that's high cost, you do a great job of controlling those costs, and you get the whack-a-mole effect and you see them rise somewhere else. So all of the work that was done with the Dartmouth Atlas on Medicare, for example, showed that there are all these areas that we're doing terrifically well in price and quality on Medicare. Come to find 3 years later that a number of those areas have really high prices on the group side. So here, because we're dealing with particular areas across multiple providers, And in a lot of these areas, you're dealing with specialists. They don't have the same kind of ability to raise prices in other places, but you're still going to expect that anyway, because some of them are large multi-specialty provider groups. You know, it's a hard question to answer, because at the end of the day, you have to keep trying, and you have to anticipate some of that, and you have to do it across the board. But it's certainly not one that anybody has tackled in its entirety yet.
And so when the insurers, so this is across, these are unit costs across whatever healthcare provider, correct?
Correct. These are for and for specific types of treatment. Julie,
Right, and they're higher in the PPO than the HMO.
Correct.
Which means it could be the same provider.
Oh, absolutely.
Wow.
Yeah, absolutely.
That's insane. Okay.
Yeah.
And just to add to that, one thing that we're doing in our work with Milliman and Peter Lee is looking across the continuum of care. So as an example, maternity care, we're looking at pregnancy, so the mom, and then the delivery, and then we're looking at the newborn care. And so you really look at costs on all ends and across the spectrum to make sure that that whack-a-mole effect doesn't happen.
So the interesting thing then I'm looking at here, which if it's the same providers charging a different price based on the insurance carriers, not carriers, but the type of insurance.
I should, before we get too far, I should say, in some cases it's the same provider. It isn't necessarily always the same provider.
Okay.
Yeah.
Is it more often than not?
That's a great question. I would venture to guess that it depends on the area. So if you're dealing with a really small area, highly likely that they're going to be contracting with the one HMO in the area and the PPO. If it's larger, a larger county, maybe not. I mean, there's considerable overlap. Happy to get back to you and look at get you a more specific answer to that question.
Because I'm curious to find out why. So we seem to have had some trouble with PPOs coming to agreements lately, I think.
I think that's a fair comment.
Okay, so that makes me wonder, is there some price gouging going on in the contractual side by the insurance carrier, and I don't know. Well,
so one other important consideration here, it's not just on the contracted side, but it's on the non-contracted side. So, some of these differences we would expect. On the utilization side, for example, we would expect that members in the PPO use less care than members in the HMO, partially because of cost sharing, right? So it's $5 in most cases in the HMO to get to do many things, and it can be 20% cost sharing if you're in a PPO. So utilization we would expect. Some of the price differences, so people go out of network more often, rarely go out of network on the HMO side.
Okay.
More often go out of network on the PPO side. So this is a combination of, these are overall costs. They are contracted prices, they are non-contracted prices, and then the contracted prices will vary depending on the nature of the contract.
Okay, so you really have to dig into the weeds, and that's what this whole process is going to be.
That's exactly what we're doing.
Okay.
Yeah.
That's what I'm just trying to figure it out. It sort of boggles the mind.
Yeah, I think one really important question that we're grappling with right now is what is it reasonable? So, knowing that no matter how good a job we do, there's going to be more out of network use in the PPO. What is it reasonable to expect? What's that baseline? So that's one of the questions that we're grappling with right now. We think this difference is too much, to be clear, but the question and the variation is particularly telling, that it's in some areas and not in other areas. But what's the right number there? And having that allows us to sort of reorient our expectations on the PPO side.
That can't be the only answer, though.
What is that? Sorry.
Well, I'm just, you're saying that trying to figure out how much of this is out of the.
Oh, yeah, we agree with you. That is unlikely to be the only answer.
It's not the only factor.
Yeah.
Okay.
Yeah.
I think, wow.
Yeah.
It's just amazing to see that. So I appreciate the work you're doing on it.
Thank you. Mr. Pacheco.
Yes, thank you, Don, for your report here, and thank you, Chairman Frickner. I want to actually piggyback on what Vice Chairman Rubalcaba was talking about regarding the top contributors for the increase in the unit cost, noticing that it's higher in the PPO than the HMO, and the top one is being the hospital outpatient service. And I just want to know if in this initial data analysis, have you noticed, are we offering like ambulatory surgical centers options, outside for the hospital outpatient services for the active members to, from what I've read, it does help curb costs, and I'm wondering if the data or the claim information can kind of give us some information into that.
So for some of these here, we do definitely use the ambulatory surgery centers, but for these treatments, they don't always fall in line with our reference-based pricing. And so the reference-based pricing has 15 different categories of things where we have a reference-based price, but those aren't always what we're seeing here as our high outcomes. So we do have a strong reference-based pricing program, and about 90% of our members use that, and it saves about $10 million roughly every year. And so these just are not reference-based price because they don't really meet the criteria to be good candidates for a reference-based pricing program.
Yeah. Currently, because we do have existing reference price pricing.
Correct.
However, it could be within the thought process of a redesign, we could add those, or it could be modified, right?
Whether it's reference-based pricing or if it's site of care or whatever it might be, but the tools to help get it the right services at the right location where they are at have high quality as well as the good price. And so this gets at the network comments as well as making sure members are aware on where to go when they have these certain things. And so it hits a variety of different things on how to try to solve this issue.
And actually that brings me to the next question, because this is regarding the patient, the member navigational programs. So that would tie in with if we were to have this established enhance the reference pricing, we would be able to utilize this new novel member navigational program, especially for the cancer cases and so forth, to help us. Or is my thinking correct on this? Or?
Yes, and so that is something that we've been having the detailed inquiries with a variety of entities that do this, also working with Anthem on how best we can help inform the member when they are in that situation, when they do have that diagnosis, on where the best care for them is, right. So they can be supported in that way as well.
And then how would the advanced primary care component delivery play into this as well?
So I'll defer to Dr. Logan.
Yeah, I'm happy to answer that. As I've mentioned and we've talked about, advanced primary care, high quality primary care is really the cornerstone, the keystone of a effective healthcare system. So we're working on the measurement pilot with Covered California, the PCP match for our PPO basic members, and looking into paying for value for primary care, because we realize as a country, as a system, we don't pay enough for primary care to be as effective as it should be. So that's what we're working on for primary care. However, primary care is necessary for a high-quality system, but it's definitely not sufficient. So there are other things that we're working on around population health management, quality improvement programs, health equity for sure, that are supporting this high-quality primary care system. And a lot of the what we're putting into our HMO solicitation around population health and NCQA accreditation for health equity will parlay into our PPO solicitation.
And as a side note, with respect to the health demographic profile information, when we start getting more of that data, would that be able to help us, help us with this advanced primary care?
Absolutely, yes. And that is, the health demographic profiles are essential to us understanding the diversity and complexity of our membership. So that will only help with the care management with advanced primary care and what we're trying to do.
Dr. Logan has several questions queued up for when we're able to do the analysis. All of them, I think, that we've talked about are related to population health and feedback into assessments about the effectiveness of our primary care.
I'm a real strong advocate of population health, so this is quite exciting. So I think my answers are all there. One last item. I know this is from what I can tell, this is a very ambitious process, an ambitious thing. What is the timeline you guys are thinking on how this could be implemented to try to kind of, curb the cost, but still provide high-quality health care for our members?
If you're talking about the PPO specifically.
Yes.
Our timeline is to bring you in November, so in a couple of months, a handful probably of recommended changes. Dr. Logan at a high level talked about the universe in that last slide of interventions that we're looking at, primarily focused at working within our existing contract with Anthem. Because we have one more year left on that contract. We've had several interactions with them and outlined in very clear terms what we expect out of the contract that we think the contract allows for in terms of getting to the ultimate goal of the larger transformation of the PPO. So that will be most of the changes that we will be recommending in 2024, for 2024, sorry, in 2023, will be within that context. The larger potential changes would be part of the solicitation for 2025. So the new contract with either this vendor or a new vendor will take place starting in 2025. So for the following year, and that's where we would envision incorporating larger, more systemic changes. And the goal is partially to mirror a lot of ambitious changes that you see in the HMO solicitation, in the PPO, but also to look more broadly at whether, for example, we might want to be engaging third parties.
Exactly.
Dr. Logan talked about several of these possibilities, including bringing people in, for example, groups that specialize in care management. Increasingly, there is a lot of focus on how to bring the best parts of an HMO into a PPO while still maintaining the things that people choose PPOs for. The ability to see a broader array of providers that may not all operate within the same system, but still do things like maintain a single electronic health record in a seamless way, have it be primary care centric, so there's a quarterback managing somebody's health and so forth. So that's those larger changes, to the extent that they would bring in third parties, would probably be 2025. But several of them, we think we can take significant steps in the existing contract.
But for having kind of like a test run or a pilot, sort of, it'll be in 2024, and that's my understanding, right? So we can kind of see how this can play out. Yeah. Very good then. Thank you so much. Thank you, Don. Thank you, everyone, team. Thank you.
Thank you, Ms. Paquin.
Thank you, Mr. Chair. Thank you so much for the report this morning. I was just curious what impact, if any, has value-based pricing had on specialist care costs?
So in terms of our offerings or in the world?
In terms of, as you're doing this analysis, have you been looking at that lens as well too, and the data that you're finding?
Absolutely. So we do a lot to try to bring more value. It's sort of why we're here. We see a number of the interventions that we've made to date being helpful in that regard. You know, the reference pricing program is a great example. See lots of data that suggests that that the various iterations of that program have led to more of our members going to high quality, lower cost sites of care, for example. I'm going to steal Dr. Logan's thunder a little bit, I apologize, but our VBID program, as we've done analysis, we think there's a lot of room for improvement of the VBID program, but we're seeing some parts of the VBID program as bringing returns. We see much higher use of primary care in the Gold program as a result of the primary care physician matching that's been in existence for some time there, and the incentives to be working with a primary care provider, and we see it in all sorts of population health measures. So I don't want to sort of go on to talk about other programs, but in general, that is where we need to be going. It's where we're focused, and we certainly see both better quality resulting in those efforts and certainly a reduction in costs.
Great, thank you.
All right, I have one request to speak from the audience. Mr. Larry Woodson. Please come up, and the microphone will be turned on, and the clock will start when you do.
Good morning.
Morning.
Larry Woodson, California State Retirees. Thank you for the opportunity to comment. CSR applauds the staff's efforts to ensure that PPO plans are aligned with the strategic plan goals. We believe the data collection and analysis is a good first step, and we do have some skepticism that in a for-profit healthcare system of vast complexity that true cost reduction is achievable short of legislation and without causing higher out-of-pocket costs for members. CalPERS in the past, a couple of years ago, has tried cost reduction efforts such as the value-based insurance design and the Castlight pilot, which didn't work out that well. But we do support this new effort, and it's very impressive what we've heard. There is a statement in the data analysis section that says, quote, PPO healthcare costs have exceeded HMO costs for the past 5 years, end quote. Yet it gives no numbers regarding total costs, and that statement is inconsistent with the data reported in the last Health Benefits Program annual report. An important means of cost comparison is the per person per year cost between the two categories, which the annual report stops short of. So I used the reported enrollment and expenditure figures and found in 2020 that HMO plans cost more at $7,129 PMPY compared to $6,903 PMPY for the PPO plans, or $225 more. However, by calculating the individual PPO plans, there's a more noteworthy result. PERS Care costs $10,489 PMPY, Choice $2,157, and Select $4,520. So Choice and Select were much lower than HMO costs, but Care much higher. And I realize Gold is now a blend of Select and Care. One explanation is that high-risk members who have chronic or serious health conditions select the PPO plan, which costs them half the out-of-pocket expense, 10% rather than 20%. And another driver is that in 17 counties there are no HMOs available, only the PPOs. The alignment write-up effort, I didn't see this addressed, and hopefully that will be looked at. There are other parts of the data collection and analysis we find very helpful, such as reporting the high-cost members and high-cost conditions and other impressive information presented. Lastly, at the stakeholders briefing last Thursday, I expressed concern that any benefit design changes from this effort should not result in the shifting of costs from CalPERS to members. Mr. Jarzambek assured me that this would not be an approach in whatever recommendations they bring forward, and I thanked him, and I thank you for your time.
Thank you very much. Seeing no other requests on this topic, Thank you all for your presentation. Great information. Let's keep holding their feet to the fire. Let's make sure we get the information that we need to make educated decisions. So thank you all. Brings us to item 6B, summary of committee direction. Mr. Sweeney, Mr. Molds, anything that picked up on?
I did not record any specific direction, but there is direction that I missed.
Mr. Chair, I just recorded the review of the foreign country direct deposits for retirees and options and communications available.
Thank you. Brings us to 6C, public comment. I do have some requests to speak. Mr. Woodson, you stayed in place. Good job.
Thought I'd save time. Good morning again. Thank you for the opportunity to comment again. My comments are on the ACO REACH program, which you know CSR opposes. As I reported in my public comments at the June 14th Pension and Health Benefits Committee meeting and in a report to all board members, it moves CalPERS retirees out of traditional Medicare and into a plan managed by a for-profit middleman without approval or knowledge of the member. I urged CalPERS to oppose this program, and I thank the board for asking staff to further investigate it and report back. Since then, I do have a couple of updates. First, in addition to the originally approved 99 direct contract entities, or DCEs, CMS announced provisional approval of 128 new for-profit entities nationwide, now rebranded ACOs. This more than doubles the original 99 and demonstrates an upscaling far beyond what would be needed for a so-called pilot project. I found that 20 of the 128, or 15%, are classified as new entrants, meaning little or no experience managing Medicare. As I reported in June, Sutter Health was approved as a GCE starting in January. At two recent CSR meetings in September, I asked for a show of hands from retirees who were on traditional Medicare who had Sutter primary care providers. About 20 people raised their hands. I then asked how many had received the letters informing them that they're now part of a Sutter DCE, and no hands went up. Since all Sutter PCPs are in Sutter Direct as of January, all their patients should have received CMS mandated letters. It appears that 9 months later, Sutter hasn't informed members, or maybe some, but certainly not all, and they're no longer in traditional Medicare. It also appears CMS is not monitoring well. With some effort, I was able to get Sutter Direct to give me a copy of their letter. It's the boilerplate language from CMS with the same exaggeration and misrepresentation that I described to you in my report. Lastly, I know that Don Moles is contacting subject matter experts for more information, and we're very happy about his plans to have a panel of pros and cons, I assume, on Board Education Day. I hope this results in a recommendation for the CalPERS board to oppose ACO REACH. If allowed to continue, it'll result in total privatization of original Medicare, allowing private equity and large insurers to take it over. Thank you.
Thank you. Mr. Tim Behrens.
Chairman Fechner, members of the committee, Tim Behrens, California State Retirees. I want to start off thanking the CalPERS health team for coming to the rescue of a 94-year-old long-term care man, and his daughter was trying to help him maneuver through it, and she sent me about 3 pages of issues, and this was passed along to the healthcare team at CalPERS, and they're on it right now, giving assistance to this lady and this gentleman. There was a lot of things that this young lady didn't understand. I call her young, she's probably 70s, didn't understand because she didn't know anything about the plan until her father got sick. So I appreciate that. I'm wondering if it's possible in the future, and I think I mentioned this the last time we met, if we could get more choices for out-of-state stakeholders for health care. I've received 14 calls from out of state, and all of them would like to have more choices. And it seems to me like it's possible for CalPERS, because they our number 2 biggest guy on the block, to leverage places like Kaiser in other states that can then cover other hospitals in other states under their agreement with CalPERS. Just a thought. I'm really disappointed that we're waiting till January to follow up on the privatization of Medicare. I'm happy we're going to do it. I would urge this board and CalPERS to do a deep dive on this. Larry gave you the statistical information that we know right now. The California State Retirees has embarked on a phone call to the president and a phone call to our congressman asking them to consider killing this pilot program. And I hope that recommendation from staff to the board will be to do the same. Thank you.
Thank you. And as you know, Mr. Behrens, we don't have meetings in October or December, so it made it a little harder to put this on sooner. So I appreciate your comments, but January seemed to be as quick as we could get there.
We need to have more meetings.
You're not going to hear an argument from me. We have one caller on the phone.
Mr. Chair, we actually have 3 callers now. I'll begin with the first one. First up, we have William Stewart. Mr. Stewart, go ahead.
Good morning, Mr. Chair and chair members. Are you able to hear me clearly?
Good morning, yes.
Thank you for this opportunity to provide comment and make an identical request by happenstance and providence that Mr. Behrens just made regarding health insurance for out-of-state retirees. My name is William Stewart. I had no idea what would be discussed at this meeting. I'm a local miscellaneous public agency retiree living in the state of Texas. I have not reached the age of 65, so I do not qualify for Medicare. Since retiring, I have been offered only one health insurance plan option. PERS Platinum PPO was the only plan I was offered last year and is the only plan offered to me during the current open enrollment period. This is, of course, an excellent health insurance plan, and I'm very thankful that my former employer is paying the majority of my family's monthly premium. However, my premium responsibility will be over $3,991 for the year, which is a significant burden for a retiree. So I would like to know if CalPERS could offer an additional health insurance plan option that would be less expensive for people like me that do not qualify for Medicare. Thank you.
Thank you. Mr. Takerts?
Mr. Chair, next up we have Paya Levine. Go ahead, Ms. Levine.
Good morning. I didn't hear anybody mention the time limit for comments. Can you tell me what that is?
Well, I didn't understand what you said. I'm sorry. 3 minutes.
3 minutes.
3 minutes.
Thank you. My name is Paya Levine, and I'm a 35-year member of CalPERS. And I called this morning because I want to tell you about a situation that our insurers periodically create for the members that has to do with the mid-year changes to preferred provider medical groups and what it's like from a member's perspective to go through that. It seems especially relevant today because we're talking about administering the PPOs. Negotiations with provider groups appear to be handled in such a way that when the providers and the insurer reach an impasse, the insurer sends notices to members saying that the provider will no longer be available after a certain date. And it's usually very short notice, on the order of 2 or 3 weeks. When that happens, it just pulls the rug out from under the members and the families who have to rely on specific doctors and specialized clinics that are not available in every neighborhood. I, for example, have a chronically ill child with a tough diagnosis. And the abrupt disruption just happened to us. I received a letter on September 7th from Anthem telling me that Stanford is no longer a network provider effective September 1st. It had already happened when I was informed. And I can't explain to you the stress that is caused when your kids' specialized providers are all of a sudden not available. I don't know if the administrators are fully aware, but it can often take years to cobble together the right providers and to get to the top of waiting lists to be treated by them. Anthem's practice of sudden cancellation is really just not acceptable, and we can do better. For completeness, I'll note that Anthem does have a continuity of care process, but please know that it consists of one final appointment, and only when that appointment has been scheduled prior to the change in the contract, which in this case was obviously impossible because there was zero notice. My request today, as your committee looks at the larger issues of sustainability with the health plan and performance, are that one, please keep it front and center that we, CalPERS, are the customers of the insurers. It's not the other way around. And I think we can require better, more compassionate performance when they're handling disruptions caused by provider negotiations. Second, insurers should not participate in brinksmanship that results in mailed notices of pending loss of care. When contract negotiations are difficult, actually that shouldn't matter, because contract negotiations should be managed so that changes only occur at the end of a contract and before open enrollment, so that medical consumers and families can know what providers are available with what plans. Many of us are completely dependent on those lists of providers because we have to be treated by certain specialists.
Thank you. Your time
A
has
full
expired.
year should be allowed to.
Your time is up. Thank you very much for your comments.
Thank you.
Mr. Takerts.
Mr. Chair, our last caller is Neil Johnson. Go ahead, Neil.
Hello? You hear me?
Hello, Neil. Good morning.
Good morning, Mr. Fechner. Good to hear from you and members of the committee. I have two comments. One is sort of directed at Don. Last fall, November, December, and earlier this year, some gentleman called in about Medicare and how expensive the PERS plan was, and there were cheaper options available. Don said he would contact them, and I thought was going to report back. I've never heard in the public meetings any discussion of what the result of those discussions were. Secondly, this aims more at Mr. Sweeney and the contact center. On August 5th, I called the contact center because I had received a billing from Mercy Medical Group over a surgery I had had in December of 2021, and asking me to essentially pay the entire bill because it turns out the provider had not billed United Healthcare, who was my insurer at the time. And when I called PERS to mention this, I got summarily cut off and said, this is a problem with the plans, don't bother us, essentially. And yet you flex fund plans, so I think you would want to know what problems are arising, et cetera. And I was really sort of shocked at the lady's summary rejection of my asking questions. I have subsequently contacted United and was able to get an explanation that the doctor had not billed. I got another billing from Mercy end of last month, and again, they hadn't billed, or the billing cycle and the automatic generation of bills weren't in sync, and so but I've been told both times I will not be responsible for the $16,000+ bill. anyway, I just wanted to let you know about those problems, and thank you very much.
Thank you, Mr. Johnson. Are there any other callers on the line?
No, Mr. Chair.
Very good, thank you. So you know the request to speak, nothing else on the agenda. We will adjourn the PHBC meeting, and we will begin the board meeting at 11:35. Staff needs some time to get the Zoom meeting set up, et cetera. So we'll see you in about 21 minutes. Thank you all.
We're in the open session of the board meeting, and we are going to go ahead and call roll. Thank you.
Teresa
Christine.
Taylor.
Here.
Rob Fechner.
Good morning.
Frank Ruffino for Fiona Ma.
Excused.
Lisa Middleton.
Present.
David Miller.
Here.
Irena Ortega. Jose Luis Pacheco.
Present.
Ramon Rubalcava.
Present.
Melissa Willett. Here. Gail Willis.
Present.
Lynn Paquin for Betty Yee.
Here. All right, we have a quorum. Our next order of business is our executive report. Mr. Hoffner? Oh, I'm sorry. Am I looking at the wrong thing? Hold on. Our next order of business is Pledge of Allegiance. So with that, I had asked Mr. Miller to lead us in the pledge.
Pledge allegiance to the flag
Of the United States of America and to the republic for which it stands, one nation, under, with liberty and justice for all. All right, thank you, Mr. Miller. So I'm going to get rid of this because this is the wrong thing. Good morning, everyone. I'd like to begin by sending out our best wishes to our fellow Californians who've seen their homes and communities so severely impacted by wildfires. I know that we had just a horrible heat wave as well this last couple of weeks ago. The state continues to find itself grappling with ever-worsening impacts of climate disruption. And as we all know, this is a crisis that requires all of us to take action, and a cornerstone of the CalPERS investment strategy as we continue to institute strategies to mitigate the risk factors caused by climate disruption. I want to express my deep appreciation to California's first responders who are tireless in their efforts to protect lives and livelihoods. I also want to congratulate all Californians who, after they got their emergency warning from OES, turned their power off so that we didn't have blackouts. So thank you very much for everyone doing that. To our members who are watching, a reminder that we have an election underway for the seat on our board representing retired members. These candidate names are on the ballots that were distributed in late August, and votes must be received no later than 11:59 p.m. this coming Monday, September 26th. The votes will be tabulated here in Sacramento on Thursday, September 29th. And results are considered unofficial until certified by the Secretary of State, Shirley Weber. If you are a CalPERS retiree and received a ballot, we urge you to vote and have your voice heard. You can learn more about the election on our website. With that, I would like to turn it over to Ms. Frost for her report.
Still morning, so good morning, President Taylor and members of the board. When we last met in July at your board offsite, we did not, have a complete picture of how the fund had been impacted by what was really in the last half of the fiscal year, significant market volatility. The report we issued to you on that date told two very different stories. In the beginning of the fiscal year, performance looked very promising. A seemingly strong market yielded double-digit returns halfway through. However, at the start of 2022, we saw the financial markets take a steep downturn. The federal government and the country really grappling with rising inflation, which is still happening today. The Fed's just raised interest rates again, as well as supply chain issues that have been with us throughout most of COVID-19. And although we're seeing some of those supply chain issues starting to correct. And then we watched geopolitical tensions grow, and then the markets definitely responded with an abundance of concern as well. We ended the fiscal year of almost polar opposites, up at the beginning and then sharply down toward the end. We did expect a market correction, but the scale of that really was historic. We posted our first financial loss in over a decade for the total fund at negative 6.1, which dropped our funded status from 82% to 71%. And that 82% was based on a 21.3% return in the prior fiscal year. In comparison to the benchmarks, we did do relatively well with the 1, 3, and 10-year returns slightly outperforming them. While the benchmarks are really a useful gauge of relative performance, we know that it is absolute returns that will pay the members' benefits and also set our employer contribution rates. From a longer-term perspective, the 5-year return is now at 6.7. The 10-year return is at 7.7. The 20-year return is at 6.9, and the 30-year return is at 7.7. That does bring me to the impact on employers and contribution rates. We did identify employer affordability as one of the key risks, so one of 3 key risks to the system. For long-term pension sustainability, an important reason why we take negative returns, even if it is a negative return in a single year, that is very important for us to pay attention to, even as a long-term investor. That being said, it is important to note that each year's investments, gains or losses, are amortized over a 20-year period, which means the impact of this year's returns will be felt over a longer period of time, slowly ramping costs upward and then leveling off. Investment returns announced in July will affect employer contribution rates based on the valuations that come out in August of 2023. Those rates won't take effect until fiscal year 23-24 for state and school employers and fiscal year 24-25 for the public agencies. I'd also like to just take a quick moment to remind employers that they can access their valuation reports through my CalPERS and then also use the Pension Outlook tool to forecast and plan for any future costs. Looking ahead a bit, over the next 10 years, we studied the lessons that we certainly have learned. Nicole Musico did a presentation on Monday of a 10-year look back of the portfolio. Really encourage you to pull that up from time to time and review it, as well as others taking a look at that, particularly around private equity. There are active ways that we think we can adapt to some of the changing circumstances around us, but also we just trust that our long-term focus and the fact that we're in a strong liquidity position, that those will bring opportunities for us to look at. Risk and return will remain a top priority, ensuring that CalPERS is appropriately paid for the risk budget that we set. And then also, very importantly, I know important to the board, we'll keep sustainability at the forefront of our strategies to protect the fund against long-term risks associated with a changing climate, human capital management policies, and numerous governance issues that we continue to watch as well as engage upon. And then we'll work with our investment partners across the globe to advocate for financial policies. James Anderson team do just a fantastic job there, as well as Simiso and his team, and also the work that we're doing around improved transparency in the markets. We'll also take advantage of the opportunities a stressed market might offer. We'll increase our capital deployment to private assets and real assets, the top performing asset classes this past fiscal year, and that decision to increase the allocation to those asset classes came through your strategic asset allocation decision back in November. And then we'll continue to build out a highly talented team who can help achieve our long-term goals. Nicole is one of her work streams that she's initiated under her time here, just 6 months in, the people strategy, which we'll be really pleased to report out some progress to you all there. But in the process and over the course of the next years, we will remain focused, as always, on the mission that's very important to all of us to be able to pay benefits to our 2 million members. That's a good segue to talk about the innovations taking place in healthcare. You just had the Pension and Health Benefits Committee with the presentation that was done on the Preferred Provider Organization Strategic Alignment Project. Like our investments, the PPO plans have been hit with some volatility as well, and they've been impacted. The rates have been impacted both short-term and long-term. The project is a thorough review of what's being done to improve the access, quality, and affordability of the PPO plans, and the team will come back in November with an updated set of recommendations for changes to the basic PPO plans for 2024, as well as recommendations for the PPO contract that will cover the 5 fiscal years after that. Just in closing, for outreach events, I'd like to mention just a few events that mark the return to in-person gatherings with members as well as our stakeholders. Last month, we held the second Pathways for Women conference in Anaheim, which was attended by about 400 people. We started this event last year to acknowledge the Women's Equality Day, which takes place every year in August, and as well as to do our part to advance diversity initiatives by inspiring women to enhance their own careers, especially in positions in leadership, whether that's in finance or healthcare. One of our keynote speakers was Chief Justice of California, Tani Cantil-Sakaue. She spoke with our state controller, Betty Yee, about her career on the bench and what it took to get there as the first woman of color and the second woman to actually serve in that role. We also had an opportunity to hear about Betty's pathway and really how she has spent her career, which was really interesting as well. All of our speakers were outstanding and enjoyed being there, I think, just as much as the attendees did. Based on the feedback that we received through our survey process and the emails that I've received, and I've received numerous emails, it really was a resounding success, and we're very pleased with the event as well as the opportunity to be able to offer it again next year. Anthony did touch on the Oakland CB, so that it was followed the same week by that first in-person CB that we've held in quite some time, 2 years to be exact. Again, obviously very popular by having over 700 attendees who decided to attend that in Oakland in person. And then coming up November 1 through the 3rd, we'll meet with our contracting employers for our annual education forum, taking place also in Anaheim. This is the once-a-year opportunity for all of our employers to gather together with our teams, whether those are sessions on how to report your information to CalPERS accurately. They get to hear from our own employees. It's a great opportunity for our team to interact more directly as well. So it is an event that we always look forward to. The forum features about 36 sessions. It will have a full exhibit hall again. One-on-one consultations. I know a very popular one-on-one consultation event is with the actuaries, as many of the employers are going through their actual actuarial evaluations or valuations with their assigned actuary. And then always a spotlight is the spotlight on excellence, and we'll have the honoree be acknowledged there. At this point, we have a little over 800 employers registered, and I think the return to in-person events is an affirmation of the important work we're doing to really connect people together. And then in closing, I just want to emphasize the forward-looking nature of our work, despite the times that we find ourselves in. Excuse me, and I'm confident we have the team to deliver upon the CalPERS mission and the strategies to meet our goals. And so with that, that does conclude my report, President Taylor, but I am always happy to take questions.
Thank you, Ms. Frost. I'm not seeing any questions, but what I want to say is I do want to recognize the Pathways for Women conference was an excellent conference. I think the first one I couldn't attend, but I did attend and participated in a panel, and it was very exciting. I want to thank the staff. I want to thank you, and give everybody just kudos for what a great job you guys did to put this on. And I look forward to continuing these conferences. So I just wanted to make sure that we recognized the hard work that went into putting that together for first, what was it, 400?
Yeah, about 400
First in person, right? Because the other one was Zoom, wasn't it?
It was. The first was Zoom. We really didn't offer a virtual option this time. We were really assessing how that might work. I think it worked, frankly, quite well. And I also just quickly want to acknowledge, even though it was called the Pathways for Women event, we had 4 of our male trustees who attended as well. So just want to thank you as well for that.
Excellent. Yeah, we did. Thank you very much for coming. All right, so let's move on. Our next order of action is our action consent items. What's the pleasure of the board?
Move approval.
Moved by Mr. Fechner, seconded by Mr. Pacheco, and I believe this is voice vote, correct? So can we get roll call vote, please? Roll call vote? Yeah, that's what I thought.
Teresa Taylor.
Aye.
Rob Fechner.
Aye.
Frank Ruffino for Fiona Ma.
He's excused.
Okay. Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willette.
Aye.
Dr. Gail Willis.
Aye.
And Lynn Paquin for Betty Yee.
All right. Motion carries. I just want to remind Christina that I vote last. Thank you. Our next item is information consent items. I don't believe I received anything asking for anything to be pulled off. So we're going to move on to the committee reports. And we're going to start with Mr. Miller, Investment Committee, please. I'm sorry, come on.
Okay. The Investment Committee met on September 19th, 2022. The committee received reports on the following topics: investment performance review and strategy, revisions to the total fund policies, private asset classes, first reading, CalPERS trust level review and annual program reviews, CalPERS trust level review consultant report and annual program reviews. The chair directed staff to incorporate analytics on GRESB and alignment with the RCP work for the November information item on RCP, which was moved from consent, and share information on deals missed with current delegation versus proposed delegations. The committee heard public comment on the following topic: CalPERS Board of Administration oversight. At this time, I would like to share some highlights of what to expect at the November Investment Committee meeting. The committee will review a second reading of the revisions to the total fund policies, private asset classes, and receive information regarding CalPERS investment strategy on climate change, consultant review of CalPERS divestments, liquidity management framework, responsible contractor policy, including incorporation of GRESB analytics, and a review of the board investment consultants survey results. The next meeting of the Investment Committee is scheduled for November 14th, 2022 in Sacramento, California. Thank you, Madam Chair.
Thank you, Mr. Miller. Our next report comes from Ms. Middleton for Finance Administration Committee committee.
Thank you. The Finance and Administration Committee met on September 20, 2022. The committee recommends, and I move, the board approve the following. Agenda item 3C, approve an extension of the current master custodian state bank contract for an additional 5 years. Agenda item 5A, approval of the elected board member proposed percentage of time to be spent on board-related duties based on board and committee selections held in May 2022.
On a report from the committee, on a motion by the committee, is there any discussion on the motion? I'm hearing no discussion. All those in favor, we need a roll call vote.
Rob Fechner.
Aye.
Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willette.
Aye.
Dr. Gail Willis.
Aye.
Lynn Paquin for Betty Yee.
Okay, motion carries. Go ahead, Ms. Middleton.
The committee received reports on the following topics: the annual actuarial evaluation terminated agency pool, 2021 CalPERS Board of Administration Special Public Agency Member Election Results, CEM benchmarking, how investment returns impact contribution rates. The chair directed the staff to provide the board with a progress report on improvements that CalPERS is making to improve our CEM transparency score. At this time, I would like to highlight some of what to expect at the November Finance and Administration Committee meeting, 2022-23 mid-year budget revisions, CalPERS budget policy, 2021-22 basic financial statements. The next meeting of the Finance and Administration Committee is scheduled for November 15, 2022. Thank you.
Thank you, Ms. Middleton. Next up is our Performance, Compensation, and Talent Management Committee meeting. Mr. Fechner. Hold on. There we go.
Thank you, Madam Chair. The Performance, Compensation, Talent Management Committee met on September 20th, 2022. The committee heard public comment on the following topics: incentive compensation criteria and benchmarks. At this time, I'd like to share some highlights of what to expect at the February 2023 Performance Compensation Talent Management Committee meeting. The mid-year status report on the CEO's fiscal year 2022-23 incentive plan, and annual review of the committee's delegation of authority. The next meeting of the PCTM is scheduled for February 23 in Sacramento, California. Thank you, Madam Chair.
Thank you, Michael. All right. Next one is Pension and Health Benefits Committee meeting summary. Mr. Fechner.
Thank you, Madam Chair. The Pension Health Committee met an hour ago. On September 21st, 2022, the committee recommends and I move the board approve the following. Agenda item 5A, approve the revised proposed amendments to section 599.500, subdivision O of the Public Employees Medical and Hospital Care Act, PEMCA, regulations to clarify a dependent's eligibility in a parent-child relationship with an additional 15-day public comment period, followed by submission of the final rulemaking package to the Office of Administrative Law upon conclusion of the comment period if no public comments are received.
Okay, on motion by committee, any discussion on the motion? Seeing none, roll call vote, please.
Rob Fechner?
Aye.
Lisa Middleton?
Aye.
David Miller?
Aye.
Irene Ortega? Aye. Jose Luis Pacheco?
Aye.
Ramon Rubalcava?
Aye.
Melissa Willette?
Aye.
Dr. Gail Willis?
Aye.
Lynn Paquin for Betty Yee.
Thank you. Motion carries.
The committee received reports on the following topics. The committee received information regarding PPO strategic alignment. The committee received public comment regarding the ACO REACH and appreciation for help with long-term care and out-of-state health care options for retirees. The chair directed staff to review foreign country direct deposit for retirees and what options communications are available. At this time, I would like to share some highlights of what to expect at the November PHBC meeting. The committee will approve the proposed regulation for the definition of limited duration employment, the 2024 Health Benefits Program proposals, and receive the 2021 CalPERS Health Benefits Program annual report and an HMO solicitation update. The next meeting of PHBC is scheduled for November 15th, 2022 in Sacramento, California. Thank you, Madam Chair.
Thank you, Mr. Fechner. With that, those are the only committees that met this month. Next up is 8 action agenda items, and for that, I'm going to turn that over to Mr. Fechner again.
Thank you. And there's been a request to separate the vote for pulling item 8A10. So I will move the board adopt the proposed decision as agenda items 8A1 through 9 and 11 as the board's own decisions with the following minor modifications. 1, insert page numbers in agenda item 8A1. 2, replace incorrect citations to section 21251 with section 21252 in agenda item 8A5. And 3, make the typographical corrections argued by staff to agenda items 8A4 and 8.
Okay, and Ms. Middleton, I'm going to wait till we bring 810 up, okay? Oh, you still have a question? Okay, go ahead.
I have an apology. I needed to pull 8A11, not 8A10.
Okay.
Ooh, okay.
I will change the motion to Approve items 8A1 through 10, and we'll take 11 up separately.
All right, thank you. On the motion, any discussion on the motion? Roll call vote, please. No.
Oh, yeah, it does.
Oh, it does? Okay. It was made by Mr. Fechner, seconded by Mr. Miller. All those in favor, I need a roll call vote, please.
Rob Fechner.
Aye.
Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willett. Aye. Dr. Gail Willis.
Aye.
Lynn Paquin for Betty Yee.
Okay, motion passes. Mr. Fechner?
I move to adopt the proposed decision at agenda items 8A11.
Okay, on the...
Needs a second. It needs a second first.
We need the second first.
Okay.
Second by Mr. Pacheco. And then discussion by Ms. Middleton. Is that what we're... Okay.
I need to recuse myself from 8A11. While I do not personally recall having any responsibility for the work of Ms. Dunlap, she did work in an assignment for a number of years for which I could have had executive responsibility.
All right, thank you. So we have a motion and a second. Can we have a roll call vote on that?
Rob Fechner.
Aye.
Lisa Middleton's recused.
Recused.
Okay. David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willett.
Aye.
Dr. Gail Willis.
Aye.
Lynn Paquin for Betty Yee.
All right, motion carries.
Agenda item 8B1. I move to deny the petition for reconsideration at agenda item 8B1.
I need a second for that, please. It was seconded by Mr. Pacheco. We need a roll call vote on that as well.
Rob Fechner.
Aye.
I'm sorry. Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willett.
Aye.
Dr. Gail Willis.
Aye.
Lynn Paquin for Betty Yee.
Okay, motion carries. All right. And we're going to move on. I apologize, Mr. Behrens. Please come up and talk for agenda item 7D. I apologize. I was thinking 8D. My bad.
Tim Behrens, I'm just going to talk as a stakeholder now. So your meeting yesterday, Mr. Fechner, made me very angry, even though you apologized. But 5 hours, closed door, 6 or 7 of us stakeholders sitting in the cafeteria all that time. Every 15 minutes, it went another 15 minutes. And then when you finally came back into session, the entire committee lasted 5 minutes, and I thought you guys were going to high-five each other. It just doesn't, I don't understand why it takes 5 hours of a closed session and 5 minutes for the meeting to take care of business. So I just wanted to share that with you. I'm less angry now than I was last night, but I still, you know, I get a lot of phone calls and emails running for office for this board, and they want more transparency. So if you're going to do a closed meeting, and I think you said yesterday you were going to report out, and maybe you did and I just didn't get it. You were going to report out about the closed meeting.
The report out is going to be at 8D today.
Okay, thank you.
All right, thank you, Mr. Behrens. All right, now we're going to move on to action agenda items, hold on. Information agenda items, 9A, state and federal legislative.
8C.
8C, I'm sorry. Diversity in the management of investments. This is James reporting AB 890.
James Andrus, CalPERS staff. For more than 25 years, CalPERS has played a role in developing and implementing emerging manager strategies, investing with emerging managers directly or through advisors. Emerging investment managers are generally described as newly formed or relatively small firms. Next slide, please. During this presentation, we will cover the items identified on this slide. In 2021, the California legislature passed AB 890 requiring CalPERS and CalSTRS to each submit annual reports on emerging and diverse managers, commencing on March 1st, 2023. Staff seeks approval of 3 items so that we may complete the report to the legislature. AB 890 requires the CalPERS board to define the terms emerging manager and diverse manager. Additionally, AB 890 requires CalPERS board to establish appropriate objectives regarding the participation of emerging managers responsible for asset management within CalPERS investment portfolio. The report is based on contracts entered into on and after January 1, 2022, and includes the name of the manager, year first engaged, amount managed, total amount allocated, and total assets under management of each asset class per year. Organizational cultures promoting diversity are vital to improving the long-term performance of our organization, as well as the businesses and markets in which we invest. Our investment beliefs state that strong processes, teamwork, and deep resources are needed to achieve CalPERS goals and objectives and highlight the importance of diversity and talent in this process. AB 890 is intended to address systemic inequality, ensure transparency, and promote the inclusion of women and minority-owned managers in the asset management industry. Known supporters of the bill include the New American Alliance, Association of Asian American Investment Managers, National Association of Investment Companies, the Green Lining Institute, the National Association of Securities Professionals, and the Investment Diversity Exchange. All of these organizations have diverse memberships and have been critical of California-based pension fund allocations to emerging and diverse managers. The proposed Emerging Managers Program objective for AB 890 remains the same as in years past. We've had this objective since 2012. It is as follows: to generate appropriate risk-adjusted investment returns by identifying early-stage funds with strong potential for success, accessing unique investment opportunities that may otherwise be overlooked, and cultivating the next generation of external portfolio management talent. This is the objective that staff asks that you approve. Staff reviewed our emerging manager definitions and proposed the following. Emerging manager be defined based on the overall firm's assets under management, length of track record, and the specific fund size. The minimum qualification thresholds vary across asset classes for reasons related to the nature of such asset classes in the public and private realm and the current market. Public asset classes will be defined solely by assets under management of under $5 billion. The change here is that global fixed income had a definition with an assets under management of under $2 billion. We increased it to $5 billion to align with global equity and fit better with global fixed income requirements. In the private asset classes, the definition is tied to length of track record, first, second, and third fund, with fund size of under $2 billion. The change here is the addition of a private debt definition as well as an increase in fund size from $1 billion to $2 billion to align with the private asset classes and recognize market changes. The proposed diverse manager definition has been updated. Applying CalPERS' initial definition of diversity as a compass, staff identified 4 demographics as diversity identifiers informing the definition. Staff proposes the definition of diverse manager be based on the total percentage of fund economics and meeting one of the following tiered thresholds. Substantially diverse would be a firm that is 25% to 50% owned by women and or ethnic minority group members and or a person of LGBTQ plus community, or where such diverse teams receive 25% to 50% of the firm's carried interest. Majority diverse is a firm that is over 50% owned by women and or ethnic minority group members and or a person of the LGBTQ plus community, or where such diverse teams receive more than 50% of the fund's carried interest. The changes in the diversity definition include the addition of LGBTQ+, as well as explicitly stating that participating in the fund's economics includes carried interest. Upon the board's approval of the objective and definitions, staff will review CalPERS' emerging and diverse manager data and draft the report for review by the board in November. After board approval of the report, staff will submit the report to the legislature prior to the March 1st deadline. Do you have any questions?
Yeah, it looks like it does look like we do. So for my question first is, so we have a difference now. We have emerging managers and diverse managers. How do we have a definition for diverse managers. How do we take part in lifting up those diverse managers if they're not part of emerging managers, or are they? I'm confused.
So the diverse managers can very well be a part of emerging managers, but we do have substantial allocations to diverse managers who are not, in fact, emerging managers. The fact is that there are several very large diverse managers that we do allocate to in very large amounts.
Okay, so, and that's going to be part of that report, so we'll see it
yes,
when you're ready.
It captures both. It captures direct investments by our asset classes with diverse managers, and it also captures investments within the emerging manager program by the asset classes in emerging and diverse managers.
All right, great. Thank you, James. I appreciate it, as always. Ms. Ortega.
Thank you for the presentation. Apologies if you said this and I missed it, but looking at the definitions on page 8 of the slides, when the report is put together, will there be a plan to disaggregate the categories, or will it be reporting on? So I guess I'll ask my question very directly, which is, will you be able to see the number of managers that are LGBTQ+, or African American, or other ethnic groups?
The legislation does not require the report to be in such detail.
Okay.
But we can track it in that detail, and we have reported that type of information to various caucuses in the legislature. So we have the ability to track it.
I do think it's really important to disaggregate that information, because when you start looking at strategies to increase or improve over time, if you don't have that breakdown, it makes it hard for you to really target the right strategies.
So we can take that as direction, if that works.
We can definitely provide that to the board.
Thank you.
Thank you. Jose Luis.
Yes. Thank you, James, for your presentation. Back to the emerging manager program objective, the definition. Now, is this the current definition now?
Yes, it is.
So I just want to clarify on the strong potential for success. Can you elaborate on that? What does that mean exactly on that definition?
That means that we're investing in great managers, and we intend on investing in managers that will meet our return objectives.
Okay, very good then. And then in terms of the emerging manager definition, which is, I believe, the new definition, right? Am I correct? How did we land at the $5 billion mark for public assets, and how did we land on the fund size of the $2 billion? Was that something that we researched? I'm just curious, or is that something that is established by the statute?
The definition is not established by the statute. We came to that definition by starting with our old definition, doing substantial research in terms of where peers are, and then discussions with the asset classes based upon their needs and their considerations.
And with respect to the partners you mentioned, I believe you mentioned the New American Alliance and the National Association of Investment Companies. Are there, because I believe, if I understand correctly, they have research as well on this. Have you coordinated with them on these particular definitions and so forth?
Yes, we've discussed our definitions with the parties listed.
Oh, excellent. And then finally, on the question on the ethnic minority group on the diverse manager definition, are those the definitions that are associated with the U.S. Census, the Latino, African American, or I'm just trying to get more understanding of that?
Yes.
Okay, very good. And that would be when the final report is taken out, will that be laid out in the aggregate, the Latino, African American, or so forth?
That's what was just done.
Okay.
That's in the direction.
Yeah. Okay, very good then. That's it. Thank you.
Thank you, Mr. Pacheco. Ms. Paquin? Ola, there we go.
Thank you, Madam President. Thank you so much, Mr. Andres, for the report. Really appreciate it. And I also like the suggestion that Ms. Ortega had. If we can disaggregate the data, I think that will be helpful. And I was just curious globally. I know that CalPERS has been working on this program for a long time and keeping data even after the last bill, some said it for the reports. But how do you envision this new reporting structure, new definitions helping the investment staff take a fresh look at the program?
I think the legislative requirement has brought everything into the focus. But moving on this program is totally dependent upon the leadership. And I think you heard from our CIO during the investment committee that it is, in fact, one of her priorities. And so that's what we are dependent upon, the leadership within the investment office to actually move on the program.
Great. Thank you very much. Appreciate it.
Thank you. Seeing no other questions, this is an action item. The intent of the item is to approve the following three things: emerging manager program objective, the definition of emerging manager, and definition of diverse manager. Can I have a motion, please?
Move staff's recommendation.
All right, moved by Mr. Fechner, seconded by Mr. Pacheco. This is a voice vote. Roll call vote, I'm sorry.
Rob Fechner?
Aye.
Lisa Middleton?
Aye.
David Miller?
Aye.
Irina Ortega? Jose Luis Pacheco?
Aye.
Ramon Rubalcava?
Aye.
Melissa Willett?
Aye.
Dr. Gail Willis? Dr. Gail Willis?
Gail, are you there? Can you unmute? Okay, go ahead.
Lynn Paquin for Betty Yee.
Okay, motion carries. If we get Gail on later, we can, I don't know if we can get a vote at that point. I really appreciate it, Mr. Andrus. And I apologize for trying to skip over my favorite person.
Thank you much.
All right, thank you very much. And with that, we're going to move on to 8D, the Chief Executive Officer's 2021-2022 Incentive Award and 2022-2023 base salary. So with that, I'm going to call on Mr. Fechner, please.
Thank you, Madam Chair. Before we get to Ms. Tucker and the agenda item, I want to make a motion for the board that we change our practice of the 0 to 7% performance scale to a 0 to 4%. And after the motion is acted on, I'd like to speak to it, please.
Okay, the motion has been made. I have a second by Ms. Ortega. I need a roll call vote on this, please.
Rob Fechner?
Aye.
Lisa Middleton?
Aye.
David Miller?
Aye.
Irina Ortega? Jose Luis Pacheco?
Aye.
Ramon Rubalcava,
Aye.
Melissa Willett,
Aye.
Dr. Gail Willis,
Aye.
Lynn Paquin for Betty Yee.
Motion carries. Mr. Fechner, go ahead.
Thank you. So considering the market environment and the CEO's decision to reduce base pay for the executive and investment management incentive program participants, she has asked that the board apply an aligned reduction to her base pay increase to be consistent with that of her team. I want to illustrate clearly that this is in no way a reflection of her performance. Thank you.
Thank you very much. With that, this is an action item, but I do want to hear from Ms. Tucker. Thank you. You're on.
Oh, ma'am. Okay, thank you. Good day, members of the board. Michelle Tucker, CalPERS team member. The board's compensation policy for executive and investment management positions requires an annual review of performance for the CEO. Agenda item 8D is an action item resulting from the Performance, Compensation, and Talent Management Committee's closed session evaluation of the CEO's fiscal year 2021-22 performance. All members of the board were encouraged to participate in the committee's performance discussion. Based on the committee's closed session evaluation, along with the incentive metrics outcomes, the resulting fiscal year 2021 incentive award for the CEO is $154,062.
Okay. Say that again, please, for me.
Yes, of course. $154,062.
Okay. And thank you. I was just going to ask for the motion for that. I need a second. Seconded by Mr. Miller, and we will need a roll call vote on that.
Rob Fechner.
Aye.
Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willett.
Aye.
Dr. Gail Willis.
Aye.
I'm sorry.
Can you say that again, Dr. Willis?
Aye.
Thank you.
Thank you.
Lynn Paquin for Betty Yee.
All right, motion carries. Michelle, thank you.
Yes, and then one more item for you. Based on the committee's closed session evaluation and in consideration of Mr. Fechner's comments, the CEO's 2022-23 base salary will be $550,730.
Okay, I need a motion.
So moved.
Motion was moved by Mr. Fechner, seconded by Mr. Miller. Go ahead and do a roll call vote.
Rob Fechner.
Aye.
Lisa Middleton.
Aye.
David Miller.
Aye.
Irene Ortega. Jose Luis Pacheco.
Aye.
Ramon Rubalcava.
Aye.
Melissa Willett.
Aye.
Dr. Gail Willis.
Aye.
Lynn Paquin for Betty Yee.
Okay. Thank you. Motion carries. Michelle, anything else?
Just to let you know, these calculations were conducted in accordance with the board's policy using the assigned ratings and weightings and the CEO's fiscal year 21-22 base salary. Thank you, members of the committee and the board. This does conclude this action item.
Thank you so much. And I just would like to point out, and it looks like Mr. Behrens is gone, this is the conversation behind all of this was why it took so long, so yesterday in closed session. Let's move on. We are now in our information agenda items. Mr. Brown, state and federal legislative update. Okay, I'm sorry. Go ahead, Danny.
All right. Good afternoon, Madam President and board members. Danny Brown, CalPERS staff, and this is the state and federal legislative update. Starting with the state side, the legislative session ended at the end of August, and now the governor has until the end of this month to sign any bills that are sitting on his desk. I was just going to touch on a few bills that he has already signed, as well as one bill that is still waiting for his signature. SB 850 by Senator Laird would provide both a special death benefit and an additional special death benefit to the children of a safety member who dies in the line of duty to a violent act in cases when there is no surviving spouse for the safety member. Next is SB 1168 by Senator Cortese and sponsored by RPEA. This would increase the $500 post-retirement lump sum death benefit for contracting agency members to $2,000 for deaths that occur after July 1st, 2023. This will bring these contracting agency members on par with state and school members who already receive a $2,000 lump sum death benefit. And then finally, AB 1824, which was the legislature's retirement omnibus bill. This included one provision that pertained to CalPERS. It made a small change to the disallowed compensation provision that passed last year, SB 278. The change now would direct all of the employer penalty to the retiree rather than have a small portion come to CalPERS. And then moving to the one bill that is on the governor's desk, SB 1089 by Senator Wilk. This was a very late gut and amend that extends the sunset date on the divestment bill from 2019 related to the Republic of Turkey. It was amended at the end of August, and it didn't go through any policy committee hearings. It was probably a deal worked out between Mr. Nazarian and the Speaker. This bill by Assembly Nazarian, the 2019 bill by Assemblymember Nazarian, had a specific condition of congressional action in order for the divestment to be triggered, and it had a sunset date of 2025. So that sunset date is now 2035, but the other conditions continue to remain in the bill. In the November meeting, I'll give a full update of what happened in the state legislative session. Moving to the federal update, since my last time before you, Congress has passed and the President has signed a major piece of legislation, the Inflation Reduction Act, an omnibus budget reconciliation bill that contains several major initiatives to address climate change and energy cost, and several important provisions aimed at lowering Medicare prescription drug cost. Many of the changes will take several years to play out, and we will work with program areas to analyze potential impacts and opportunities as these initiatives are implemented. In addition, we have submitted several comment letters to federal regulators. Earlier this summer, we submitted a comment letter to the SEC on their proposed rule for climate-related disclosures. We also submitted 2 comment letters to the International Sustainability Standards Board, the first one on their draft climate-related disclosure standards, and then one on their sustainability-related financial disclosure standards. And then just last week, we submitted another letter to the SEC in support of their proposed rule to clarify when public companies may exclude shareholder proposals from their proxy statements, and then one to the PCAOB on their 5-year draft strategic plan. All of these letters are posted on our website. Looking forward, we are currently working on 2 more comment letters, one to the SEC on their 5-year draft strategic plan, and then one to the CFTC on their request for information on climate-related financial risk. And then I know I've probably said this 2 or 3 times to you already, but we do think the SEC is close to putting out their proposed rule on human capital management, and obviously once that comes out, that will be a priority for our team. And then finally, now that Congress has returned from its August recess, there are only a handful of business days remaining before the midterm elections. We expect the Congress to focus on passing a continuing resolution to keep the government running past the election. And then, depending on how the election turns out, will dictate on whether any work gets done during the lame duck session, including a retirement bills that both the House and the Senate have been working on and we've been watching closely. So in November, we again should be able to give you a recap of the outcome of the election as well as what we can expect the rest of the year. And with that, I'm happy to answer any questions.
Thank you, Danny. I am not seeing any questions from the board right now, so thank you very much for your report. Oh, there you are. You weren't there a minute ago. Go ahead,
Sorry.
Jose.
Thank you, Danny, for this info. I just want to understand. I want to know just a small update. It's one of our sponsored bills, the HR 1187, Mr. Congressman Vargas's bill, which is a consolidation of other bills that are going in. I noticed that it's still it's referencing it's still in the Senate Committee on Banking, Housing, and Urban Affairs. Is it still there, or is it going to be heard in this new in these coming months?
It is not likely to be, heard in this year. I mean, a lot of these are messaging bills that can get out of the House, but then they just go to the Senate and there's no movement. So we're not expecting anything probably to happen with those bills this year.
Okay, thank you very much.
All right, thank you very much, Danny. I appreciate it. With that, I believe we are moving on to summary of committee direction, board direction.
Yes, Chair or President Taylor, I noted the one, and that's the disaggregation of the diverse manager investment report for the board.
Thank you. And with one more thing, before JJ makes public comment, I just need to make a note for the record that Lisa Middleton is changing her vote for 5A from an aye to recusing herself as she was not here for the June meeting. So I wanted that on the record. Public comment, and with that, Mr. Jelensik.
JJ Jelensik. I missed the investment committee because I was celebrating the fact that my wife put up with me for another year. Historically, CalPERS has been a leader in investment performance. As this board has delegated more and more authority to the staff, it has become an investment performance laggard. Correlation is not causation, but the board really needs to step back and take a hard look at what's going on. The proposed change to delegated authority is another example of the board giving up authority, but I remind you that you cannot give up responsibility. The law, which is the trust document, makes it clear that investment authority and responsibility lie with the board. It is on you that CalPERS owned the National Enquirer. The staff has come to you and asked for more authority. Staff said you should be comfortable giving this authority because they're going to do a better job of tracking and coordinating their activity. That's good, late but good. Staff said that it was improving investment oversight. However, it is clear that the oversight being improved is not the oversight by this board over its agents, which is what is in fact needed. Thank you.
Thank you, Mr. Jelensik. And with that, I'm going to go ahead and adjourn the open session. We have lunch in the back for the board, and we will come back to closed session at 1:15. Oh, okay, hold on a second. We might have a different story here. Nope. All right. Open session is adjourned. We will be in closed session at 1:15. Thank you. of open session. We are now going to adjourn open session. So thank you very much. We will see everybody in the Ed Forum and then at a November meeting. So drive safe, and thanks, everybody. Thank you, Gail. Do I have stuff I need here?